Guys, let's talk about superior thyroid artery ligation and related injuries. See, this is your superior thyroid artery, STA, and near it, shown in this side, not in this side, but we have in both sides, we know, right? This is your superior thyroid artery, and this is your superior laryngeal nerve. Okay, see, these two are very, very close. Okay, these two are very close. Superior thyroid artery, in this side you will find it here, and here is your superior laryngeal nerve. See, medially we have superior laryngeal nerve, and laterally we have vagus. Okay, and this vagus goes down, goes down, goes down, and somewhere at the point it remembers that larynx, I haven't supplied all of it. Some of the part of larynx is left, so it gives a recurrent branch. Recurrent branch means it takes a U-turn. On right side, it takes U-turn behind subclavian, and on left side, it takes a U-turn behind the arch of aorta, or around, whatever you say it. Now, thing is that, see, this is your superior laryngeal nerve, and here is your inferior laryngeal nerve. Because it's taking a U-turn, we call it recurrent laryngeal nerve. In short, RLN. So now we are clear about it, that vagus passes and gives superior laryngeal nerve, and somewhere along the point in left side near arch of aorta, and in right side near subclavian artery. Subclavian artery, it gives a recurrent branch, that is recurrent laryngeal nerve or inferior laryngeal nerve. Now, when you know this, let's talk about artery. This is your common carotid, and it branches into internal carotid and external carotid. Just to show you clearly, this external carotid gives a fast branch of external carotid, that is your superior thyroid artery. Superior thyroid artery, that is very near to this superior laryngeal nerve. Now, superior laryngeal nerve branches into two branches into internal laryngeal nerve and external laryngeal nerve. Now you see, now you see, if if you see from side, you will see it's branching here. It's branching here. Now, if it branches here and the superior laryngeal artery is coming out from here, there is a step in thyroid surgery. You have to ligate this vessel right here. So see, what are the nerves that are close to it? Laterally, it's very close to vagus, and medially, it's very close to external laryngeal nerve. Now, thing is that this external laryngeal nerve can arise here or up here, because we have anatomical variations. So, we can injure either superior laryngeal nerve or external laryngeal nerve or vagus this side, because your recurrent laryngeal nerve is nowhere near around the superior thyroid artery, nowhere near. You can't injure that. So this is the first concept you need to know. Because the superior thyroid artery is here, if you ligate it, you can injure either external laryngeal nerve or internal laryngeal nerve or superior laryngeal nerve. Internal laryngeal nerve injury is very uncommon, but these two is very common. Superior laryngeal nerve and external laryngeal nerve. Now, in your exam, you will have questions with presentations that the person undergone this surgery will present with any of these. Which are these? If they say that person presents with loss of high-pitched sound, and we know high-pitched sound is caused by cricothyroid, and that's supplied by your external laryngeal nerve. So you are very sure you have injured external laryngeal nerve. Now, if you see you don't have external laryngeal nerve in your option, so what have you injured? You have superior laryngeal nerve. Very easy, because external is a branch of superior laryngeal nerve. You can injure either superior laryngeal nerve or external laryngeal nerve fibers inside superior laryngeal nerve. So if the person can't produce, if the person can't produce high pitched sound, you have injured either external laryngeal nerve or external laryngeal nerve branches inside superior laryngeal nerve. So your answer will be external laryngeal nerve. If that's not an option, your answer will be superior laryngeal nerve. Now, if you have injured directly superior laryngeal nerve, or your questions say that the person can't cough, so you have injured both of them. So you didn't injure both of them separately, but you have injured both of them at their origin, that is superior laryngeal nerve. This is your medial side injury. Now, can't you injure a nerve that is very lateral and near to it? Yes, you can. You can. That is vagus. And what will happen? What will happen? See, if they say the person has a hoarseness of voice, but hoarseness is of voice is caused by unilateral recurrent laryngeal nerve injury, but RLN is nowhere near to this superior thyroid artery. You ligate here. How can you injure a nerve that is here, that is down there? See, let me show you again. That is very much down there. And see, this is your superior thyroid artery, and this is your recurrent laryngeal nerve. It is almost impossible. It is almost impossible. I will say impossible. It is almost impossible to ligate here and injure something down here. So you have injured the RLN fibers inside the vagus. So in short, you have injured the vagus, not directly RLN, but RLN fibers inside the vagus. So that's why you will have hoarseness of voice. I think it's very, very clear. Now I will show you just some points about parathyroid gland. Now, see, this is your inferior thyroid artery. Let me show you this one. This is your inferior thyroid artery. Let's add endocrine system to see. This is your parathyroids. This is your two parathyroid gland just behind and inside inside the fascia and very much close and to thyroid gland. So during thyroidectomy, you can injure those. Now, we have a question. Which of the arteries supply parathyroid glands? This is your inferior thyroid artery, and this supplies your parathyroid gland, the superior parathyroid and inferior parathyroid, both of them. Both of them. See, these are your inferior thyroid artery, and it supplies your parathyroid glands. And this is a very important question. You will have it. During tracheostomy, remember we have two lobes. This is your left lobe and this is your right lobe. And in between we have isthmus. And remember, we pierce the isthmus during tracheostomy when we do it in hospital. When you do it in hospital, in elective setting, you pierce isthmus. But remember one thing, when you do it in emergency setting, you pierce this membrane. This is your cricothyroid membrane. Remember, how do you recognize it's an emergency? They will say that you are trapped under a big building, or you are a rescuer and the patient is trapped under a big building, and you are doing it beside that building or somewhere or in ATLS, wherever is it, you pierce the cricothyroid membrane. Okay, thank you.